Thank you very much, Afshin, and good afternoon, everyone. It's a great pleasure for me to be here and present you this new Alphenix 4DCT platform. Here are my disclosures. As you know, Angio-CT has evolved for 3 decades now, with the very first one in 1992 here with Professor Ahai. And from that one, we have in 1999 a CT sliding gantry. And then every single evolutions of both the angio part and the CT part in the next generations of the Angio-CT system, up to some very important evolutions, such as the wide area detector CT, a little bit more than 10 years ago, up to the latest advance in deep learning reconstructions I will share with you at the end of this presentation. Each step pushed us closer to the treat, plan, and verify in a single room. In 2017, we had the privilege of being the very first to install a 4DCT system with wide detector, then soon followed by our centers in France and across Europe and the rest of the world. And as you can see now today, the installed base has dramatically expanded with nearly 280 systems worldwide, clearly demonstrated strong clinical adoption of such systems. This new 4DCT combines the new Alphenix Sky Plus C arm with upgraded flat panel detector with the Aquilion ONE Insight edition, bringing together 16 cm coverage, 0.24 second rotation, integrated deep learning reconstruction, all within 80 cm bore. And that's precisely this combination that makes true one-room IR possible. Now, some words about the installation in Montpellier. We have a relatively compact room. As you can see, the examination room is a little bit less than 50 square meters. We have also the technical and the control room here. Building on our experience with the prior 4DCT system, everything was simulated in advance, not only the parking positions, but also the full range of movements of the table, the CT, and the C-arm. We also modeled the workflow of the medical staff, radiographers, anesthesiologists, as well as the ceiling-mounted equipment, such as the large display or protective shields. You have here a video showing the teamwork and how difficult it is to install such a system in a working operating room without interrupting surgery and liver transplantation next door. For example, the rails, the ground rails for the CT gantry had to be built with an extreme accuracy because the system must know every time the exact relative position of the CT, the C-arm, and the table to enable seamless image co-registration across modalities. This was truly a massive work done by the Canon's teams, carried out over a 3-month period. And as you can see on this video, heavy access was done through the OR facade to keep activity running during this work. So this is the outcome of all that work. You can see we have now a full multimodal room integrating angio, CT, and ultrasound in the same IR suite. We started the activity with the first patient only 1 month ago, meaning that we have only a limited experience of this new system, but the evolution was really immediate to capture. As you can see, with a single button, we can now shift every single modalities. It's very fast and seamless, and the workflow is clearly improved from the very beginning. But before diving into clinical cases, first things first, patient installation is key. We are using such dedicated system on the table to maintain a patient's arm above the head safely, without any risk of stretch or neurological injury. This is a crucial detail because we make sure that we can use CT in every circumstances safely and with the best possible image quality. Now, we can see how it works in practice on the patient. We can see that the switch between angio and CT is now extremely simple. Again, only one button to press, and everything is working all together. And as you can see, it's much, much faster than any cone beam CT system. And then we go to the CT part. And here, everything has changed. First, Instincts is now available. Instincts has been released recently in Canon Diagnostic CTs, and now for the first time is available on the 4D-CT system. What is that? This is the traditional Scout acquisitions have disappeared and have been replaced by an ultra-low dose helical acquisition using silver beam. This acquisition also has auto-landmarking, meaning that AI automatically detects and locks the target field, as you can see here for liver imaging. And this works perfectly in a higher environment. The additional benefit of this helical acquisition is that we can check and refine very precisely the scan range and the acquisition dose we want to obtain. Then we move on to a typical testation. For example, we put the cat in the celiac trunk and we inject contrast medium following this protocol. And we have just one single rotation to do, meaning that we have no apnea necessary, no breath hold. This is nearly instantaneous. We have a 16 cm coverage of the whole liver with very fast reconstruction time, even with the latest deep learning reconstruction algorithm, but we'll come back to that later. Then the volume is extracted very quickly. We can manipulate the volume. We can extract the vascular tree. This is nearly automatic, and only rarely do we need to edit the volumes manually, as we have done in this case. Even here, it was a very fast process. Within seconds, you get your complete vascular tree. You can see there are so many vessels because now the precision has strongly increased, but again, we will see that at the end of the presentation. And then we have an automatic co-registration between real-time fluoroscopy and 3D model. Really automatic, no manual adjustments needed. It is a strong improvement. And obviously, the 3D model follows any C-arm movement in real time as well, as you can see. Obviously, this 4D-CT system has many dose reduction tools. You may remember from the previous one, the live zoom function. Instead of conventional magnification, which is increasing the dose you deliver to the patient, the live zoom keeps the dose neutral by zooming in like a numerical zoom. Now this function has expanded to the live zoom plus function, where we can zoom in into any part of the image. It's very simple. Again, we keep dose neutral. It works like pinching with two fingers on a smartphone. It's very easy, and we have been using this function every day over the past month. The image quality is absolutely nice, keeping the dose very low. The feeder detection software workflow is straightforward. As you know, tumor segmentation is semi-automatic. It works very fast. Then you have just to click on the tip of the catheter, and the software extracts all tumor feeders very quickly and overlays them on the 3D model. Then you can manipulate this 3D model to check the feeders and to choose the most appropriate angulation for 3D roadmap. Again, 3D roadmap is instantaneous, co-registered, no manual adjustment needed, and obviously this is correlated to the movement of the C-arm in real time. Now we move on to the first clinical case I would like to show you. This is a patient with several HCC nodules we would like to ablate. Unfortunately, one was located in the dome, but all of them were not visible under US. The reason why we decided to inject lipaodol in the hepatic artery to tag the tumors. For the dome lesion, usually we are using this kind of approach, an intrathoracic route, with injection of CO2 in the pleural space to clear the lung from the needle path. This is the way we are routinely performing such ablations. But now we have the possibility of using a different approach, even for very complex trajectories, such as this one, a triple oblique needle insertion. And you have this tool, which is, again, very straightforward, where you can see the red points highlights precisely the structures you are supposed to cross and shows where the tip of the needle should be located on each side. So it's a very simple and rapid means to get complex needle path. And to be honest, this was my very first case with this function, and with only a limited number of CT checks with small 3D volume acquisitions, I was able to put the needle at the right place in the target without passing through the pleural space, so it is an alternative of what we are doing usually for such dome lesions. In this case, the other nodules located in the left lobe were accessed using conventional 2D CT fluoroscopy after protection of the stomach with injection of CO2. And you have here the immediate control, where you can see the nodules are all tagged by lipaodol, and you can see very well the margins around, which seem all satisfactory. The second case I would like to share is this one. This is a quite atypical case. This is a recurrent solitary metastasis in the left lobe after right hemiapatectomy. Unfortunately, this metastasis is large, centrally located, and also located close to the earth at this upper part. So we decided to use both IRE and microwave to ablate completely this tumor, which was unfortunately not visible or not clearly visible under US. The reason why we decided to use arterial CT portography to insert the 7 needles necessary for this treatment. So after we put a cat in the superior mesenteric artery with small amount of contrast medium, we can see very well the tumor and put the needle in place. A very interesting new features, very, very easy, is this switch from a conventional red laser to now a green laser. This is a good idea because clearly it helps us to align the needles much more easily than previously. And in this case, it was very easy to put all 7 needles in place. You have here an almost final CT check with all needles in place, so 6 IRE needles, 1 microwave needle. And then we use dedicated software usually used for metal implants. We use it for colorizing the needles. It's a very interesting function. We can select with 1 click each needle. We can colorize these needles. This is clearly helpful for recognizing which needle is which, and this is very interesting for IRE especially. We can then select the most appropriate multiplanary formation with the objective to measure each distance between needles. You know, this is critical to enter into the IRE generator to obtain appropriate currents for ablation. So you have here the needles, the IRE needles and the microwave needles at the upper part to treat the upper part of the tumor not far from the earth. This is the final CT control before ablation. And you have here the MR scan performed at day 1 showing complete tumor ablation with wide margins, including the central part and the upper part of the tumor. With the new features I showed you and the ability of co-registrate everything with everything, this can be very helpful even for extremely complex procedure. This was a nightmare. Probably the worst case, the most complicated case I had ever to face. This patient was recanalized for chronic portal vein thrombosis. We did a portal vein recanalization plus tips using a transfusional approach, but because of JAK2 mutation, the patient thrombosed its tips very quickly, and we had to go back and plan a new tips through the first tips. It was a tips, trans tips, but it was really difficult to find our way to patent jejunal veins. By using co-registration with a prior CT at the portal phase, we could help us guiding our guide wire and our stents to patent jejunal veins. We also use subtraction imaging, so many features. I have no time, unfortunately, to detail with you, but I will come back probably in the coming months on this new feature that might be helpful in such complex cases I couldn't do before. And now we move on to probably the most impressive evolution with PIC. PIC is the new Canon's precise IQ engine, which delivers super resolution. You can see images with 1024, so 1K metrics, sharper images, less noise, and no additional dose. It was initially designed for cardiac imaging, recently transposed to body imaging, and now in the 4D-CT system. You have here head-to-head comparison with between what we had before, the iterative reconstruction on the left, and the new PIC on the right. Please pay attention that we are looking at very thin slices, 0.5 millimeters. The difference is striking. Another example here, even compared with ACE, PIC brings image details and precision to a whole new level, as you can see here. Another comparison, we leave you some seconds to look at this video, between what we got before, the ACE reconstruction algorithm, which is something quite new, and the new PIC reconstruction algorithm. This is amazing what we can now see, the fine details. And as we'll see, I will zoom in to the image. You can see the difference. This is clearly huge, especially with CT arteriography images we have ever seen before. If you do MIP reconstruction, you can see so many vessels. It's amazing. If you translate it, for example, in the portal system, I don't know if you have ever seen such subcapsular and capsular portal vessels. I had never seen that before. And probably, given the high level of detail we have with PIC, we have to relearn the anatomy. And this is clearly something we have to do. And what is interesting is this is not only images designed for showing you today, wow, it's amazing. These images are used every day because the reconstruction time is very fast. So you can use them in your daily routine practice. Now we move on to the last part. The last part is about 4D imaging. As you know, 3D imaging should be regarded as a snapshot, as a picture, like this ends. And if you talk about 4D imaging, then you add the element of time. And to think about that, you need to, for example, to look at this end moving. We can now capture movements of structures. And if we go into a whole organ, we can also capture the blood flow, for example, here in the brain, by reproducing with this large detector CT in continuous acquisitions or repeated acquisition with high temporal resolution, we can capture the flow dynamics and perfusion in real time within the 4D-CT room. How does it work in practice in liver imaging? It works very well. The workflow is straightforward. If you have a 4D acquisition in continuous mode with maximum temporal resolution, 9 seconds, during the CT arteriography. And what is now impressive is the reconstruction time, which is very fast, meaning that we can get the first 3D sets nearly immediately. You can use them for 3D roadmap, like on this case. So these data sets are reconstructed within seconds. You start your catheterization, you start your embolization, and within minutes, then you get 4D flow images. You can see them in multiplanar reformation. You can take a look also to volume rendering technique. You can also take a look to MIP, single MIP coronal view, showing how many vessels now we can look at. It's really impressive. And again, probably we need to relearn the microanatomy Look at that. It's really amazing. Clearly, I don't know which artery is which. There are so many. And again, this is obtained in routine practice. It was our first case. Here, second example, the same. This is a huge adenoma in a young female patient. And this adenoma was considered unresectable. So we decided to embolize it. And we did exactly the same I showed you before. So we did a 4D acquisition using our classical CTA protocol. And we used the first 3D data sets obtained within seconds to guide us for 3D roadmap and for embolizing this tumor. And within 6 minutes, we obtained these nice images showing not only the large vessels we all know, but also, I don't know if it doesn't work, unfortunately. You can see the tumor vessels. Remember, this is a benign tumor. You can also see that there are so many other adenoma that were not depicted on MRI before. So these images are really informative. Now they can be obtained in routine practice at low dose. And because we can get 3D data sets very quickly, we can use them nearly every day. Now comes the conclusion. With this new system, Alphenix 4D-CT platform integrates the best of CT and angio today. Everything has become now easier, faster, and more user-friendly. Now we achieve outstanding image quality at low dose every day. This is really, really amazing to see. 16 cm coverage, I know this is more expensive, but this is necessary. This is necessary because with that, we can use 3D guidance, 3D verification for every single procedure every day. And the same for 4D acquisitions, because now, because of this 16 cm wide detector CT, we have 4D acquisitions entered in routine practice. My final word is, now, 4D-CT truly earns its name. I would like to thank warmly all Canon Medical teams from Japan, from Europe, from France. Also a big thank to my team, radiographers and doctors for following me in this adventure. Thank you very much.
Thank you very much, Boris. Any question or remarks of the room? And Boris, another question. Are you systematically putting a catheter now when you do ablation of the liver?
Yeah.
That's the same thing with us, and that's something we need to understand. That many teams, you remember, Martin in Amsterdam is doing this from angio room to the CT, and yeah. I think having both in the same room is key.
It's key. We save time. We save time also for diagnostic imaging, and clearly the total cost of care is reduced. So clearly this kind of room is expensive, but if you take into account the fact that the diagnostic CT is supposed to do some higher procedure and then won't do any higher procedure anymore because it's not necessary, we can do everything in one single room, and we spare the time for changing between the diagnostic and the interventional suite. At the end of the day, it helps us to pay the price for the CT systems.
And then for anesthesiologists moving from one room to the other one, they have headache. And finally, one thing which is key, again, you understand it, that's the team. You know, I'm happy that my team is here. Without a good team, which is managing technicians and nurses, managing this is impossible. When people want to visit us, I'm telling them, please bring with yourself one of your technicians and nurses. You agree with this? Because that's the key.
Fully. Without radiographers, we can't do anything. And they are really, really involved in such a system because they can see that technology helps clinical activity. It's really, really key.
I'm always telling you are the control tower. We are flying, but they are the control tower. You agree with this too?
Sure.
Anyway, thank you to all the team and technicians who are participating in the meeting. Without you, we cannot work. Without nurses, we cannot work. That's always a teamwork. You just see us, but we are just a superficial part. But behind this, that's a huge team. And again, with such a room like this, so complex, you agree that we need a very dedicated team. They should not turn around, because in UK, we have the problem that they turn around our technicians. Is a nightmare.
Absolutely.
That's another cost too.
Yeah, absolutely.
Boris, it was wonderful. I loved it. I'm still jealous, but I loved it. Thank you so much.
Next time you